Je vous propose de commencer. Les derniers participants vont arriver au fur et
Let's
à mesure.
start. I'm sure the participants will join us as we go on with our session, our second session, in fact, our second morning, dedicated to access to drugs, organized with operations. Two sessions today. One regarding the management of cancer patient and the followed by nutrition, malaria, and pediatric health. I'm going to hand over to Pierre Mendy Harat, who is head of operations, who is going to moderate the first session. But first, a few housekeeping details. As obviously we are on Zoom, there are two channels open to panelists. They have a microphone function to allow them to interact with the audience and with as if they were in the room. So you can raise your hands to ask questions. And there's also a channel dedicated to the audience, which can be used in order to ask questions and make comments. It's in the toolbar under the discussion or chat tab. So Pierre will moderate the discussion, and I will forward the questions to him that I get from the chat. Please, as a reminder, try and speak slowly and clearly to facilitate the work of interpreters, and to make this even easier for them. Please use a headset with a microphone, if possible. Yesterday we had 1 hour and 30-minute sessions with a coffee break in the middle, just like yesterday. And there's going to be a 30-minute conclusion session, a wrap-up session to try and see what sort of conclusions can be drawn from our 2 days of work. Thank you very much to all of you for being with us today. And without further ado, over to Pierre. Thank you, Pierre. Thanks a lot, Michael, and hello, everyone. Thank you very much for your attendance today, and more particularly for those of you who are not MSF members and who are trying to give us a hand to give some thought to these issues. And in particular for this session, Dr. Fatoumata Sidibé and Professor Jean-Paul Vernon. We're going to focus on cancer for the first session. Just a few seconds, sorry. Right, I hadn't located my microphone. Right, so back to square one. I was just saying that despite the proportion of the limited proportion of cancer patients in low and middle income countries where we usually operate as MSF, cancer is on the rise in these countries and is bound to increase and to sort of quote unquote catch up with the high income countries. And there's a major share of cardiovascular diseases in the disease burden, and the greatest increase in cancer is going to come from low and middle income countries, some 80% in the years to come. Cancer management is characterized by great discrepancies in the access to care. Less than 50% of low-income countries can offer a full management of cancer patients, as opposed to what you have in high-income countries, where 90% of cancer patients can be treated. And when I say full management, it means access to diagnosis and treatment, and also prevention, as obviously some of these cancer diseases can be prevented to a certain extent, either by a change in hygiene and in living conditions, diet, So it's a new area for MSF. There are two major cancer projects at MSF focusing on the treatment of cancer patients in late stages. It's this is in Mali and Malawi. The activity started respectively in 2018 and 2019. These are two projects led by MSF France. There's also an MSF Switzerland initiative. They want to start a cervix or breast cancer, I can't remember exactly, in Kurdistan. And also there's been a Kaposi syndrome or the cancer lesions in the cervix that led to initiatives. However, no specific specialized programs per se. In Bamako, we are involved in screening and we participate in the pathology lab, palliative care. Now, the number of patients in this program in Bamako correspond to some hundreds of patients. It does shed some light on how difficult it is to manage these programs in Malawi. This is a screening program for cervix cancer surgery, immunization. Some 9,000 children were immunized, but no radiotherapy, no chemotherapy. So for cancer management, what matters is not just access to care or access to drugs. Cancer programs involve a wide array of programs and such as screening, diagnosis, biology, treatment, chemotherapy. So we're going to start our discussion on these issues. We are going to have two initial presentations. The first one given by Dr. Fatoumata Sidibé and then Claire, and then we will give the floor to Jean-Paul Vernon, who is an expert in this issue, on these problems. So Dr. Fatoumata Sidibé works in the hematology department, and she graduated from the Hospice Civil de Lyon, and she has a master in biology from the University of Besançon. So the question to you, Fatoumata, is to ask you to try and explain to us how things are done in practice in Bamako. As a clinician, what sort of obstacles are you faced with these patients? So good morning to you, Fatoumata, and I'm sure someone is going to handle your slides for you. Thank you very much, Pierre, for this introduction. I'm very happy to be with you and to tell you not about myself, but about the situation in the everyday life for these cancer patients in Mali and oncology in particular. My slide reads medical oncology, but I'm going to touch upon surgery, but I will focus mainly on medical oncology. So here's the map of Mali with a surface area, because it's just to highlight the fact that it's a very large country. It's a vast country with a surface area of 1,241,238 square kilometers, with a population of 20 million inhabitants. There are several regions in the north, Timbuktu, subject to a lot of problems recently, and then in the south, Bamako and Sikasso. Hopefully you can see my pointer on the screen. So you can see that Bamako is in the southern part of the country. It's very far away from Timbuktu. And the major problem in oncology, once the diagnosis is done, and we can see we have just a few centers in Bamako that can deal with these cancer patients, though very often only partially. So just to give you an overview of the health system in Mali, how is it organized? First, you have public health structures, health facilities, but also private health facilities and also traditional healers. But I'd like to focus on the public health facilities. They are organized as a pyramid. So you start very close to the communities and patients are referred upwards and there are also health districts divided in health areas with community health centers. When these community health in these community health centers, you don't have a lot of technical equipment. Most of the time they have a gynecologist, a few nurses, and when they feel overwhelmed with the situation, they refer the patients to the reference health centers that are slightly better equipped with, they have more staff and more technical equipment. It's breaking up, Fatoumata. Your connection or it's breaking up. Can you hear me? Yes. The third level is in Bamako with the university hospital. And there are also private health facilities, profit-making facilities from very high-level centers or smaller ones. There are also non-profit making centers in these private health facilities, usually funded by NGOs, by the community health associations, or called the ASACO. And there are also some company medical centers, INPS, and also the, I mentioned here, the popular pharmacy of Mali, the PPM, and traditional healers, even in Bamako, and irrespective of the income bracket of patients, but more particularly for poor patients, people who are less well off and for whom access to hospitals is more difficult, and therefore they tend to turn to traditional healers.
Est-ce que les autres, chez les autres, c'est comme ça parce que quand je vais parler des traitements, je vois que c'est barré. Enfin,
I can't see my slides. We can see your slide perfectly well. Now, the management of cancer covers several areas, as Pierre has just explained. Prevention is very important, like leading a healthier life, screening, treating precancerous lesions, such as for cervix cancer, immunization, in particular to prevent cervix cancer, or even liver cancer, which most of the time is can be attributed to the virus of hepatitis B. Hepatitis B vaccine is quite expensive and isn't reimbursed, and it's even worse for HPV. And we do the screening to screen for precancerous lesions. However, we don't do that for colon cancer. It's not feasible in Mali. Now, after prevention, of course, there is diagnosis. If you suspect a cancer, it should be confirmed by the histology through biopsy or cytology or surgery. It should be sent to a lab to confirm the diagnosis. Once the diagnosis is confirmed, then you go on with staging to identify where the cancer is located, whether there are metastases or not. This is what the staging phase. We can rely on X-rays, of course, ultrasound, CT scan, MRI. There's one MRI in Bamako, but it's in a private health facility. It's very expensive and therefore can't be used for the majority of people. And also bone scan and PET scan. There is a nuclear medicine unit. However, it stopped operating since 2010 or 2012. There is a bone scan equipment, but it's not operational. And we never had a PET scan, i.e. the latest generation equipment. PET scan is very important because it shows the dynamic evolution of the lesion. So PET scan tells you whether the lesion is active or not, whether it is part of the sequelae from a well-treated and controlled cancer or not. And bone scan is very important because it gives you the mapping of the skeleton and tells you whether the cancer has progressed to the bone. Because you can't really have X-rays of every bone, it would mean too much irradiation for the patient and not such a valuable result. Then once you've done the staging, you go on with treatment. It can be a local treatment with surgery. Surgery is something we can perform as well, and radiotherapy, but as you can going to see, radiotherapy is not always easy to offer in our country. And then there's also systemic treatments, chemo, as everybody knows, and chemo is usually something you can get access to almost everywhere. Targeted therapy is something which requires a more sophisticated technology, and it comes at a cost. And there's also immunotherapy that can help the patient to restore his or her immunity to fight off cancer. But these are very expensive drugs, like 3,000 to 5,000 euros per injection, something you have to go on doing for many years. And then palliative care for end-stage cancers, and this is what we see in 80% of cases because the diagnosis comes too late. Now, in Mali, what about the diagnosis? I told you how it's done, and once the diagnosis is confirmed, people must be seen at Bamako. The public hospitals that can offer either partial or total management for cancer patients are the teaching hospital of Kati, the Gabriel Touré, the Mère Enfant teaching hospital, and the Hospital of Mali. There's also the Lyota, the ophthalmologic or the odontostomatology national center, and so on. So the histology diagnosis is done early in the Point G, in the pathology lab, and the pathology lab has been refurbished by MSF in the framework of our partnership with them. In some cases, the Hôpital du Mali can be involved. There's a partnership with China, but this is not sustainable. Let's say that roughly everything is done at Point G for histology. So even if diagnosis is the sampling is done in CATI or elsewhere, everything is sent to Point G. Now, just as a warning, Fatoumata, I think you need now to focus on your daily practice, clinical practice, because there are only 10 minutes left for your talk. So I've told you about the staging. For chemotherapy, now this is what I do every day, and it's done only at the Point G teaching hospital and the mother children teaching hospital with some subsidy from the state, 280 million French CFA francs, and we are constantly faced with shortage of drugs. So people stop their treatment because they don't have the means to buy the chemotherapy drugs. And obviously this leads to tragic failures of treatment. Thanks to MSF, since 2018, 2019, they support us for totally for breast cancer and cervix cancer and for palliative care. Radiotherapy for the treatment of cancer, as I told you, there's chemotherapy, radiotherapy, surgery. These complex treatments are absolutely indispensable to hope to cure the patient, and there's only one radiotherapy equipment in our country. In the Hôpital du Mali, you have to wait for 3 to 6 months in order to get treatment. So once they are done with chemotherapy, they wait for so long for radiotherapy that either they get a relapse or the disease is progressed, and therefore it's too late, and they come back to us to start over another line of chemotherapy.
J'ai oublié de dire, il y a un seul appareil qui est d'une ancienne génération, donc on aimerait bien avoir d'autres appareils, mais comme le VMAT. Alors pour la distribution du médicament, juste pour vous...
Now regarding the drugs, with this envelope, we have a meeting with PPM and DPM to express the needs, but they are quite limited because we have to make sure that the products are in line with the budget. If the drug is not within budget, it has to be suppressed, or if the quantities are too high, also they will have to be reduced. Once we've done our math, PPM, the People's Pharmacy of Mali, will launch a call for tender to pharma labs or individuals, and will buy the product for the oncology ward at Point G or the Mère Enfant teaching hospital. Then there are the private pharmacies where they can try and import the drugs
à l'étranger, au Maroc, ou encore plus cher et plus compliqué au compte-gouttes pour le patient.
And they buy from Morocco or from Europe, but the prices are very high because of customs clearance and tariffs, etc. Next slide. So these are the obstacles to cancer management. So there is only one laboratory for pathological analysis with up to 1 month or even more before the results are published. They're also limited because they do not have access to molecular biology, So some targeted therapies such as cetuximab, which is a revolution for colon cancer, cannot be prescribed because we need to know whether it is possibly efficient to treat a patient, but you need to have molecular biology results. Gefitinib, we also may prescribe trastuzumab once the cancer is sensitive to this drug with this receptor. I've already talked about nuclear medicine. The fact that the geography of the country means that all patients will have to go to Bamako. Ideally, we should have oncology centers that would be helping people and patients not to systematically go to Bamako, and the other limit is drugs. We need more medicines because since 2018, as you can see on the pie chart, the number of cases has doubled almost from 8,000 to 15,000 cases in 2020. Same observation in our department, where in 2017, as from the end of 2016, the second center was opened, and in 2017, we've also witnessed a higher number of consultation. So 5,000 consultation and 3,000 in 2017 in a ward. So we've doubled the number of patients where the credits and the end budgets were the same, which does explain for the shortage of drugs, etc. Global CAN has shown also that within the next 10 years, the number of patients will go up again and again. These are a few suggestions to improve care. Ideally, we should have full treatment available, the whole range of treatment solutions with a national oncology center for a proper management with surgery, chemotherapy, and we would also need to have access to targeted therapies such as cetuximab and immunotherapy. And also we should have access to palliative care solutions, because sometimes we also have some patients who are coming at a late stage of the cancer. Make sure that we have a decentralized solution so that people in Tombouctou and Sikasso shouldn't have to travel to Bamako to find accommodation or live with relatives in Bamako because it's too long. It's the source of conflicts with the family. It's a burden for the families there. So along the same lines, we would also need to decentralize the technology and provide a CPD, that is continuous professional development solution, and capacity building for medical and paramedical staff. We only have 7 oncologists, 4 radiotherapists, and dozens of specialists for pathological analysis. We only have 3 oncology surgeons, but there are other specialized surgeons such as gynecologists, for instance, who have had some training abroad or who've learned on the spot with their colleagues to provide treatment solutions. So, and also ultimately, Mali should further develop basic research and clinical excellence in order to meet the needs of our patients. Because today, we know that we treat 1 patient and 1 cancer, so we need customized solution treatment. so that we have a case management that is similar to what is observed in developed countries, even though the types of cancer are not necessarily the same. That's all I had to tell you. I hope I was within the time I was given. I wanted to talk about all the difficulties at the same time, but it's difficult to give an overview. And I hope we can discuss it further in our debate. Thank you. Thank you, Fatou. We will take some comments afterwards, and I'll give the floor now to Claire Rieux. Claire Rieux, who's been working with MSF for more than 20 years. She's now the head of the medical department. She's specialized in clinical hematology. For several years, she was the head of the vigilance department at Henri Mondor Hospital in Créteil. And she's been working with us in 2017 on the new oncology programs with the creation of the support teams, which is based here at the head office with a network of experts. So my questions to Claire is, can you give us your vision on the tools to be developed for settings such as Bamako, for instance, and for MSF, what MSF could do to make this treatment available to patients? Claire, you have the floor.
Voilà, merci beaucoup. Bonjour à toutes et à tous.
Thank you. Good morning, everybody. And thank you, Fatoumata, for your presentation, which does indeed reflect the reality. My finding out of the situation in Mali as a hematologist in charge, as an MSF doctor and a former cancer patient, I was deeply moved when I saw the magnitude of the needs. And I've realized that there were physicians, doctors who were very dynamic, who were extremely frustrated, even though they were experienced, but they didn't have the tools and the means. Beyond the lack of resources, they couldn't help their patients, and it was a source of great frustration. And they had to adapt to the protocols as a function of what the patients could afford, or whether the radiotherapy equipment would work or not. So it's extremely complex. It's not only about vaccines and drugs. There are things that are absolutely needed for sure, but if you want to provide a proper case management for the vast majority of cancer cases, you need to have high quality surgery and radiotherapy, which is a key element for cancer treatment. There is a huge bottleneck, as Fatou has said. There's just one piece of equipment for too many patients. Patients have to wait, and that's missed opportunities for patients. And so it raises the question of equipment. There are several occupations also, dosimetric specialist, radiotherapy specialist, and maintenance. It is something that we're well aware of at MSF for the field, but which is not always mentioned. But the maintenance of biomedical equipment is a real challenge in terms of access, even though it's not so visible or so quote unquote sexy, and we don't know how to improve this. With this disease, we can even try and treat based on symptoms, because the outcome is a disaster. Sometimes you have patients who have tuberculosis and were treated with chemotherapy, or they have benign tumors and they were treated with cancer drugs that are very toxic. So the side effects are huge. So diagnosis, a proper diagnosis, is paramount. The other difficulty is that we say the cancer, but there are several cancer forms and diseases we've decided to target. breast and cervical cancers. And I'm hoping that in the future, we will be more open on other types of cancer. If we want to go beyond our own specific projects, we will have to try and see whether we will deploy tools for all forms of cancers or only the ones that I've mentioned. So in terms of case management, you see that there are many commonalities to be tackled. The other issue which was discussed yesterday is that having high quality drugs and radiotherapy equipment is important, but we should have them available to the patient and with a high quality level. You could have, for instance, for chemotherapy molecules, and then Jean-Paul Vernon will tell us about the situation in France, but we know that there are some approaches today, some initiatives that have helped the American Cancer Society, which is the biggest patients association in the United States, is powerful, did with the Clinton Foundation negotiate with Pfizer and Cipla to reduce the price of molecules for basic chemotherapy molecules that are still used for 80% of cancers. Such mechanisms do exist, but how can we make sure that these drugs will be properly distributed, well supervised, and reach the patients? So the access from the product to the patient, how can we make sure that this is working? Another comment that I would make, my third comment, which is also specific to cancer,
en mixant différents types de traitements, les délais sont très importants.
the delay are too long, too much time between two chemotherapy sessions are missed log opportunities. These are huge systems. People are lost in this complexity of sessions. So the patient's pathway is also very important. And these were some progress in the Plan Cancer in France. Jean-Paul Vernon has worked a lot on this plan. He will probably tell us more about it later. So we should make sure that some people will make sure that the patient will have the treatment on time and find out why the patient didn't show up because he didn't have any money or didn't understand the process. These are very important aspects. No, I'll try to be optimistic because I'm raising many gloomy questions here. No, why should MSF go for that? Of course, we should go for that. And there are other initiatives also, but I think that we're at a time which is an opportunity, even though it's only incipient. Some countries are developing universal health coverage, so reimbursement of the treatment of these diseases, and innovation can also help make access easier. When we talk about telemedicine or telepathology in terms of expertise may sometimes fill the gap for the shortage of experts in some instances and can help have access to international experts. What has helped to improve diagnosis in France are the multidisciplinary meetings. It's not only one physician who makes a treatment decision, it's a group of doctors with the surgeon, radiotherapist, radiologist, surgeon, etc. They will review the patient's case and record, and then they will plan the treatment. And some of our colleagues in Africa have already attended such meetings and organize such meetings. For telepathology, as I call it, it gives the opportunity to scan the pathological specimen blades and have them analyzed by other experts worldwide. Same for mammography. And then artificial intelligence can also help to a certain extent to do a preliminary sorting or screening. And this will help fill the gap of human resources. And I'll stop here, and then we may discuss about it further later. Thank you. Thank you, Claire. We did ask Jean-Paul to be the third speaker. Are you with us, Jean-Paul? No, he's not with us. He's had some connection issues, but that's okay. Jean-Paul is a professor in oncology, and regarding the drugs, what he wanted to say was there are two types of problems regarding these drugs. 85% of the drugs that are used today in France are not covered by patents anymore, but there is a shortage because laboratories are no longer interested in manufacturing them. And we'll try to understand why generic manufacturers do not make them. And even in France, it is said that some generic manufacturers have plotted and organized a kind of shortage to help the prices go up. And the other problem, there is a price problem imposed by laboratories. And according to Jean-Paul, these prices quite often have nothing to do with the actual cost of R&D. Before starting the debate, are there any clarification questions on what we've just heard from Claire and Fatoumata? Any clarification question on any topic that they would have covered in their presentations? Well, if there are no questions for clarification, for the debate, is anyone interested in taking the floor? Isabelle, maybe you were in Mali recently. Isabelle introduced herself yesterday. She spent quite some time in Mali recently and reviewed the oncology activities there. Maybe you can respond to what we've just heard. Thank you, Pierre. I think that Fatoumata has clearly explained how difficult and complex is the management of cancer in Mali. Nevertheless, they're doing their utmost, and practitioners have managed to provide care to a higher number of patients. And Claire has clearly explained that the bottleneck is radiotherapy. This is what we're going to work on, and we're working on it. It's not easy to have a network of radiotherapists in Mali, but this is something that we're working on. And there is also one thing I would like to emphasize that Claire has mentioned, which is a coordination of care. There are many case management solutions, and patients are lost. As Fatoumata explained, there are different sites, different teaching hospitals, and where they have to go, where scheduling the sessions is extremely important, and make sure that people can complete their treatment is a crucial issue. And it's difficult indeed to coordinate this pathway of patients, and this is where we have an added value. And there's one thing that Fatoumata has also touched upon, and which is a problem as I see it, I think that there's very little work done on the vaccine, that is the prevention of cervical cancer. Information about it is well known in MSF, but it's not on the top of the agenda, and it has to be done simultaneously with case management of patients. And another area which is also key to me is to make sure that these cancer projects will be successful is everything that is related to early diagnosis. 80% of the patients have a too late stage in the disease to be properly treated, and that's really a problem. Early screening and of cervical cancer is something well known. We know what are the areas for improvement. For precancer lesions, we know how to detect them. There is the HPV test. And for breast cancer, there is very little. And as I see it, except for radiotherapy, the other items which to me are extremely important are prevention with the vaccine and proper diagnosis and early diagnosis. And it will have to be on the top of the agenda of our projects. Otherwise, I'm afraid the outcome will not be satisfactory. And I would like to know what can be done in terms of early diagnosis for breast cancer. And I would like the viewpoint of Dr. Fatoumata on this aspect. What is it that we can do to be more involved in performing and providing early diagnosis? Alors, so regarding vaccination, from my understanding is that HPV vaccination is a problem today. Can you turn on your camera? HPV and early diagnosis of breast cancer.
Donc, pour la vaccination HPV, les données sont là. On sait que le
HPV vaccination, we know that up to 2 years ago, cervical cancer was the leading form of cancer in Mali, with
environ, selon les pharmacies, entre 100 000 à 150 000 francs CFA. Donc,
the price of the vaccination is from 150 to 200 euros, where the lowest wage level does not allow for that. There were meetings held by the health authorities involved in the screening and prevention programs. We can't hear you, Fatoumata.
Le circuit du cancer a été validé pour une prise en pour la population. Il n'y avait pas de médecin. C'est ça qui a été le quag. Et depuis, en cours
derrière. The problem
derrière,
was that there was a shortage of physicians and doctors to help for this diagnosis. And we also need to convince the authorities that the vaccine is absolutely key to solve the problem, to help solve the problem. And when we talk about vaccines in Mali, people are afraid. There are misconceptions, negative messages stating that
du grand public, c'est des produits que les Occidentaux, les Blancs,
these are products that were developed by the whites to make African women sterile. This is their hearsay about that, to prevent growth of the population. So there's a whole education effort to be made.
N'a pas de but de rendre infertile.
to explain to patients that the physicians are not there to reduce the fertility rates and are not making women sterile. So since you're talking about women and young girls, so everything that has to do with young girls is marred with all these misconceptions. This is a huge effort also to be made. Even if it's free of charge, if there is no awareness raising campaign, nobody will show up for a vaccine. When it comes to breast cancer, there are some awareness raising messages such as a breast palpation, but it's mainly mammography. I didn't detail it, but in Bamako, there is a mammographer which was at the Point G, but it was out of order for many years. Currently, it is in operation, and there is another one in another public teaching hospitals. And there were some mammography equipment at the CCF in private clinics, which were never used, unfortunately, because the equipment was sent out and shipped and delivered, but they didn't have any qualified radiologists to perform the mammographies. So in Sikasso, there were some devices which were given by the state and they remained in the rooms and unused. So radiologists have to be trained. You need a double reading of the mammography. You need to have experienced radiologists who are used to that. And in order to avoid a high number of false negative or false positive. And they have to be performed at a reasonable cost. It's between 10 to 20,000 CFA francs or up to 30,000 CFA francs in a private clinic. So it's not affordable for the population, the general population, particularly when you cannot guarantee a proper double reading. There were two questions which was raised on the chat regarding access to HPV vaccine related to what Isabelle has said, to try and understand the barriers to access HPV. And Suma also said, you're talking about 150 euros for the HPV vaccine? Yes. You have 2-dose vaccine. You can have a booster. So there's the injection is 150 euros because it's sold by private pharmacies. It's not available in the public system, not even in the pharmacy hospital, in the Point G pharmacy. These are the misconceptions also, because people, the target population of HPV vaccines are young girls before they start their sexual life or right after having made the HPV test to make sure that they do not have the virus. You can vaccinate them. In some countries, it is said that even if the test is positive, people can be vaccinated at a later stage. Since these young girls are the target of these vaccines, the misconceptions are that there is an intention to sterilize them.
So that's the main obstacle in the general population. And the other obstacle is that the decision makers didn't deem it necessary despite the very high rate of cervical cancer, is the #1 cancer in the population. It was the case in the past. It's now the second most frequent form of cancer. Well, unfortunately, the decision makers haven't decided to introduce it into the vaccine that has to be administered, and that should be free of charge. Now, Delphine, I don't know whether Delphine can take the floor. She is mentioning something here about 2 vaccines licensed globally and quadrivalent, and I'm in Bordeaux with MSF Logistic. It's pre-qualified. This vaccine has been pre-qualified. I haven't asked about the price or possibility to access this vaccine, but I think it should be feasible. Alain, you shouldn't forget that Mali is supported by Gavi, and it seems that there was a pilot project at one point in time. I think it is 350,000 euros to buy HPV vaccines. But I think that, like Fatoumata said, you have to look into what sort of negotiations there were with the MOH. If the Chinese vaccine has been pre-qualified, it can be channeled through Gavi or bought with Gavi's money. However, there must be a discussion with Gavi about the vaccines that they want to support. When I was in charge of Malawi at the start of the program, it was exactly the same problem. In theory, everything could be accessed through Gavi, but there were so many obstacles that at the end of the day, the vaccine wasn't widely used. Well, Malawi has introduced the vaccine nowadays and is going to benefit from Gavi's support, which isn't the case for Mali, because obviously the authorities in Mali haven't decided to include it into the compulsory vaccines. And then the distribution capacity for Africa is more reassuring because there are new recent HPV vaccines. So in terms of supply, there should be enough doses so that Gavi can supply more countries with this vaccine. So in terms of advocacy, if you think that cervical cancer is a priority in Mali, I think you should target the Malian authorities and Gavi so that they can come up with a solution to set up a program very quickly. Isabelle?
Il va y avoir tout un temps et des difficultés pour rendre les vaccins HPV disponibles.
I can see the obstacles on the road to making these vaccines available to all young girls. However, I think the basic minimum requirement would be to offer this vaccine to daughters of women who presented with a cervical cancer. Maybe upfront, we don't have to come up with a solution that would cover all girls in Mali, but at least do something that would make it possible for daughters of women with cervical cancers. Do you have anything to add on HPV vaccines? Pierre, I've got a very short question. I'm really appalled by the cost of the HPV vaccine for patients. What is the price of this vaccine in France that is reimbursed by the National Health System? How much costs this vaccine? 20 to 30 euros, I think. 20 euros. So it's a factor from 1 to 7 between France and in the global south. Now, it's not really the global south, it's the private sector in Mali. Gavi doesn't pay the price you pay in France for these vaccines. So the idea here is to make sure that the price that is paid by Gavi isn't associated with a major increase once it goes through the private sector channels. In Malawi, the Gavi price was under $5. But it didn't work that well. I can see someone in the chat mentioning the cost, Felix. I don't know whether someone has asked this question, but is it a priority for the governments and the authorities, the health authorities in these countries? If it's considered to be a priority, then you will get the necessary means to buy the vaccines. And as someone was saying, it requires a huge mobilization for young girls to be vaccinated. But at least it should be considered as a priority by the government. So I think it would be the first block, the first step. Jean Hervé.
Yeah.
Lina, you can talk. So excuse me, Jean Hervé, I will give you the word now. I've seen your hand, but Lina was commenting both on this question of prices of HPV, but also you had interesting comments that I want you to develop on the fact that MSF in India is already working on the issue of the medicines out of patent, going out of production, and you work on it on antibiotics, and you could extend that on cancer. And I think that's an interesting comment. How does it work? What you can achieve today in antibiotics, and it could translate to cancer. Lina, please go ahead.
Sure. So thank you. I mean, this problem of older medicines going out of production is quite deliberate by the pharmaceutical industry, which has been discussed. So in India, some of the work on, say, MDR TB was to go back and talk to the producers and work with them for them to revive production in a, sort of a pre-qualified quality assurance manufacturing, plant. And number two is to sort of bring in a pool procurement mechanism, which is, something that we've been advocating now for the older antibiotics. So as part of the work that I do in India, with Krista and Dusan, we have just started to do a survey of the problem of the older antibiotics just not being available to treatment providers. And I feel that, this work could be extended for cancer as well. If there are older medicines that are absolutely needed, getting back and doing a project with producers to get them reviving those drugs or finding sources of those drugs, doing work on quality assurance and figuring out a pool procurement mechanism so that they have the incentive to make, bigger volumes at a lower price. So that's some of the work that's quite common between different diseases of older medicines going out of production. So I just wanted to share that it's quite interesting. This is also a problem in India where older drugs go out of production once they are not, lucrative. And the second thing I wanted to say, and I'm not at all worked in Africa, I'm a very Asian person, I just wanted to say that, like with HPV vaccine, I'm part of the feminist movement. And what I've really noticed is that twofold is the fact that it's part of sexual health. You have to give it to, young women, adolescents. Governments have not quite figured out how to deliver these vaccines through school programs and all of the issues that come around sexuality, sexual health. But the other big issue is this, that governments have to take over from Gavi. And once they realize they have to take over from Gavi, they are very reluctant to take on that vaccine, which is like one of the most expensive vaccines, the same with the pneumonia vaccine, the same with the HPV vaccine. And I just wanted to highlight that we need to find a way of bringing down the prices of the HPV vaccine if we wanted to go into universal immunization programs. Because even that $5 price that Gavi gives is sometimes too difficult for governments to sustain in the long run.
Thank you, Lina. Thank you. Just, I'm reminding everybody to put the camera when they are speaking. Et je vois que Jean-Paul a finalement pu nous rejoindre. Donc, bonjour Jean-Paul.
Please make sure that you switch on your camera when you're talking. Now, I can see that Jean-Paul has been able to join us, and maybe we can ask Jean-Paul to switch on the microphone.
Est-ce que tu nous entends?
Jean-Paul, can you please switch on your microphone?
Il faut faire passer la soupe. Voilà. Là, vas-y, Jean-Paul.
Là, c'est bon?
OK, Jean-Paul.
Is it okay like that? Now, Jean-Paul, I'm so glad you could join. Unfortunately, we don't have a lot of time left for your talk. But maybe you can contribute to our discussions with regard to the price of drugs. And I'm sorry, because I couldn't really hear what you said before. What I can say is that we've got a lot of problems in high-income countries such as ours. So I can well imagine how difficult it is in other countries. There are two types of problems. First, there are older drugs no longer covered by patents, and which are not very attractive, not at all attractive for the pharmaceutical industry. It's not lucrative enough, and so they don't care. So what they did is that they outsourced the production of these older drugs to India or China, and they no longer produce these drugs. Now, there were 100 pharmaceutical companies, but they consolidated. And this concentration led to only 10 to 15 large pharmaceutical companies funded by hedge funds, by pension funds, and they are forced to do an awful lot of money. And because the older drugs correspond to 80% of drugs used in cancer treatment, well, they really don't care. All these older drugs, we need them, but these big labs, because they've outsourced their production to Asia, to smaller producers, we are faced with shortages. So we need to try and solve the problems of production of these older drugs. Now, of course, Big Pharma would rather focus on therapeutic innovations that are much more lucrative. They don't care about making money with cheap drugs prescribed to a lot of people. In lung cancer, there were 3 types of cancers. There are now some 10 to 15, and depending on the presentation of the cancer, some of these patients are going to be treated with cures that cost 100,000 to 200,000 euros per year, and this corresponds to therapeutic innovations, and it jeopardizes the budget balance and leads to a problem for the social security system. So what should we do? Why is it so costly, and how are the prices set? Now, some 30 to 40 years ago, pharmaceutical companies registered drugs at a reasonable price corresponding to what they had spent on R&D. But most of the time, Big Pharma doesn't perform R&D. R&D is done, whether you take, say, Germany, France, or Japan. It's the academics do the job, and the industry benefits from the academics' R&D work. Plus, it takes up to 15 years to market a drug. It used to take 15 years to market a drug. Now it's down to 3 to 4 years. So the pharmaceutical industry can't really argue that they should price these drugs, new drugs, at a very high level because of R&D cost. And they spend only 15% on R&D versus 25% on marketing. Roche, for instance, in 2021, cashed in 62.8 billion euros. And it corresponds to 23, and they had a profit of 23.7%. Because they want to, they charge very high prices because they say they've improved the medical service rendered, which isn't true. In fact, it's not true. Their estimates for the price are based on what they think the market is ready to pay for these drugs. How many dollars or how many euros per patient per year? This is the case in the US. It went up from $30,000 to $120,000. The medical service rendered is the same, but it's just the market is ready to pay more. So what can we won't be able to afford these drugs for a very long time unless there is a differentiated pricing policy, which raises other problems. Jean-Hervé, do you want to say something? Can you please switch on your camera? Now, of course, we should call into question Gavi and national authorities that don't really take into account their population's needs, or not all their needs. But I think we should cater for ourselves. We should look at what we must do and strive for more consistency. I know it's not easy, but obviously our session this morning shows that the various stakeholders in the cancer treatment, each participant holds a part of the information, and we find it a bit difficult to build up a global vision. Now, the HPV vaccine is a good example of this situation. I think we've been working on cancer for 4 years in Mali and Malawi, cervical cancer, that is. So I think that between ourselves, we should now have something a bit more robust and a level of information that would be more consolidated. And Jean-Paul Vernon has mentioned all the drugs, and it's true. It's one of the first problems we were faced with 20 years ago with the Access campaign. And this is how we turned into global distributors of some drugs, such as the drugs needed for HAT. Now, maybe it's because thanks to my seniority that I can say so, but I can see that information is fragmented, is scattered across the MSF network. We have the information, but it's not centralized, it's not consolidated. And I think that, well, this points very clearly what should be done for MSF medical directors. And I don't want to sound too critical here, because I consider that it's also I'm also guilty of a lack of consolidation of information. But this strikes me from in our discussions this morning. Anyone willing to comment on what Jean-Paul, Jean-Hervé have said?
Oui, je suis tout à fait d'accord avec le diagnostic de Jean-Hervé. On en a déjà parlé plusieurs fois.
I fully agree with Jean-Hervé. There's a a lack of coordination, a lack of information consolidation within the movement, and even within OCP. And what we said about HPV, the HPV vaccine, is something we could replicate for other issues. And indeed, we need to work together more closely so that we can move forward on a number of issues we want to tackle more efficiently. Now, I want to ask something of Fatoumata. In cancer, some chemotherapies are very expensive, others are much cheaper. Older chemotherapies for which there are generics of good quality, though some old drugs are see their production stop. But it seems to me that in Mali and in West Africa, more generally, one of the problems for the governments and the clinicians is to know how to get these generics, high quality generics. And is it still a problem, Fatoumata? Because you were telling us that some tenders are issued, but do you think that in Mali, clinicians know where to buy these generics? It seems to me that this is a problem not only to for patients, but also for the state, for the authorities, and for the doctors. Yes, it's a problem. When we try to look into this, you see, it's fairly complex because the people have their supply system. They don't want to change their supply systems, and the decision makers are not the clinicians.
Donc ils font un peu de l'administratif et ils ont du mal à venir vers nous, ou même nous, l'inverse. Donc ils font des appels.
So these tenders are issued, sometimes private labs, or they tell us that they turn to the cheapest one, and it changes every year because obviously they can't pick the same supplier every year. Whereas what we would rather have would be to source these drugs from India, for instance. We've already had these discussions with MSF, and we could have partnerships with these producers, and we could get access to older drugs so that we can guarantee supply. And the larger the volume, and even in India, if we were to have a partnership, a collaboration with an Indian producer, of course, we would have to look into the quality of the products, but we offered such a solution. Well, at least it could solve part of our problem. And of course, this wouldn't cover the latest innovative immunotherapies that can't be produced by generics manufacturers. But we don't know, they don't want to do this. So they keep on issuing these tenders every year, and it seems to us that they're not even negotiations as such. And so we're faced with shortages over and over again. So we tried with an Indian lab. However, the suppliers are in Senegal, and patients can buy, but as individually, and it's not the and the hospital, Point G hospital, doesn't get involved. It's the patient himself or herself who buy from this supplier in Senegal, and so they have to pay for the shipment, of course. So it makes this even more expensive. Julien. Yes, it's interesting to see this difference between these older drugs that are very cheap, no longer covered by patents. It's a bit like what we could see for penicillin G or for older antibiotics. They're old, no longer covered by patents, so no one wants to produce them. So how can we maintain the supply of older drugs, such as, of course, for vaccines as well, like the BCG vaccine, which is also affected by this? Now, I think we could have a global approach, not only for vaccines, but also for older antibiotics. My second comment is on the monoclonal antibodies. At the CAM, at the Access campaign, we've decided to focus on monoclonal antibodies. There's going to be a first meeting to ramp up our knowledge on this subject. We're going to invite external experts. You should know that the offering is being fleshed out in India, and their business model is really to lower the prices of trastuzumab and other cancer blockbusters. So I think we're going to witness a revolution thanks to the Indian industry. They're going to drive the prices down. I was lucky enough because I could meet them in 2009. 2019, and they're really very aggressive. They're going to drive down the prices of these latest therapies, and it could prove very interesting for countries such as Mali. Thank you very much, Julien. There's still 1 minute for us to for this session, and unfortunately I have to leave. We're going to leave it there because there's another session after this one. I won't attempt a summary of our discussions. There's obviously a need for setting out priorities and more consolidation of information, as Jean-Hervé was saying. Now Hélène was meant to attend, but for personal reasons, she could not do so. And she was mentioning the possibility to include the cancer drugs in the essential drug list, and the problems of access. And also, as she said, there's a need to include anti-cancer drugs in the pool. And she also wanted to say that patients associations, patients groups affected by cancer are more and more numerous, and that maybe we can use take advantage of these groups to push advocacy. Now it's 10:30. Thank you very much to all of you for your contributions. I can see that Michael is on. Thank you. Yes, I'm sure we could have gone on. There was also a comment in the chat on the Bios Club in India. And Pierre, we could have, of course, mentioned this with you because you're involved in this work, access to drugs through marketplaces. And now, of course, we will have other opportunities to mention this. I invite you to attend the second session dedicated to nutrition and malaria. It's going to start in 15 minutes. Please stay connected so that we don't have to accept you again to the meeting. So 15 minutes and we are back at 11:15. Thank you.
Allô, Michael?
Salut Marie-Hortense.
Salut.
Ça va?
Oui, bien, et toi?
Très bien. Alors, on va vérifier. Adeline, est-ce qu'elle est là, Adeline?
Bonjour Marie-Hortense.
Ah, Fatoumata, très contente de
C'est contente de te voir.
Ben oui.
Oui, bien.
Salut
Toujours
Adeline.
à Dakar.
Oui, je suis à Dakar, là, ouais.
Et Kevin, good morning, sir. Salut. Bon, bah, c'était pour vérifier que vous étiez là. Et puis, il manque Philippe Dunton.
Philippe?
Ouais, il manque Philippe. Bon, il ne devrait pas tarder. Hein.
Tu m'entends bien? Pas trop de bruit, je mets le casque.
Moi, je t'entends très bien. Est-ce que Adeline et Kevin, vous pouvez aussi dire un mot pour qu'on voit si tout va bien?
Bonjour, est-ce que vous m'entendez bien comme ça?
Super, Adeline, merci.
Super. Casque.
Kevin? Kevin, on ne t'entend pas là. Non. We can't hear you. Adeline, est-ce que tu as un casque?
Non, je n'ai pas de casque.
D'accord, ah ben, on fera ça. Donc, il faudra parler voilà, tranquille et tout. C'est juste pour la traduction, c'est plus simple, vraiment doucement, parce que ça fait toujours un petit peu d'écho. Et Kevin, we need you in. Ouais.
Allô?
Oui?
OK. 5 sur 5?
Ouais, il y a Kevin qui se rebranche, je pense, parce que... Attention maintenant. Parce qu'on n'avait pas Kevin là. On n'entendait pas.
Can you hear me? Can you hear me now?
Yes.
Okay.
Yes.
Great.
Perfect.
Great, great,
Okay.
great.
You almost scared us.
I quit.
Bonjour, Kevin.
Bonjour Marie-Hortense. Bonjour Adeline.
Ok.
Bonjour Fatoumata.
Bonjour.
Et donc, il nous... Voilà. Bon, bah, on va... je vais vous libérer. Hein. On ne va pas attendre 10 minutes là à se regarder, mais on attend... vous pouvez éteindre vos caméras, prendre un café, et puis on se retrouve... je sais pas, dans 7-8 minutes, quoi. Dans 7-8 minutes. Et puis, j'espère que Philippe Dunton sera avec nous. À tout de suite. Hein.
Allez, à tout de suite.
À tout de suite.
À tout de suite.
Check. OK.
Je voudrais juste dire bonjour à Fatoumata.
Bonjour.
C'est Ousmane, docteur Ousmane, Épicentre Niger.
Bonjour, docteur Ousmane.
Bonjour, docteur. Ça va?
Ça va bien, et le grand Mali?
Et on est là.
Je sais que le combat n'est pas facile. Hein, j'ai bien suivi ta présentation. Avec intérêt, quand on connaît le Mali dans sa dimension, dans ses diversités, le problème de cancer, j'ai personnellement, lorsque j'étais au point G, j'ai vécu des situations qui n'est pas du tout facile. Et quand les praticiens, tu as des patients, tu vois, si tu ne peux rien faire, c'est parfois il y avait beaucoup de désolation. Hein. C'était
Ah oui. Je
avec
disais ça souvent, c'est à force.
Avec DAPA à l'époque.
Avec le professeur Dafa qui est à la retraite. Notre cher maître.
Oui, effectivement, ce que tu dis, il y avait, ça c'est des trucs isolés, mais c'est réel parce que on avait une petite fille qui avait une leucémie lymphoïde, quelque chose comme ça, qui venait de Bandiagara. Alors, le monsieur, lui, il avait environ combien? 5 enfants. Donc, toute l'économie qu'il avait, y compris maintenant le transport, c'était devenu difficile. Et on a fait recours, tu sais, et aussi, il y avait la fête aussi de Tabaski qui arrivait. Donc, lui, il dit non, il ne peut pas rester. Il n'est pas le seul enfant. On a dû recourir dormement et puis avec les étudiants, tu vois ce que ça pouvait faire. Quand même, on a eu des résultats, il y a des choses comme ça. Et l'autre chose que tu avais dit, les abandons, quand tu vois, j'ai aussi rencontré une dame à Sirakoro. On lui a dit rendez-vous, je ne sais pas si c'était à l'hôpital mère-enfant ou bien je ne sais pas 6 mois que de revenir. Et avant les 6 mois, qu'on avait ça. Donc, est-ce que au cas où une canata là, tu vois des choses qui peuvent. Donc, ton vécu, ce que tu as dit, c'est vraiment réel. Et puis, moi, je suis au Niger, mais je suis de Banyangara. Je suis un médecin qui travaille avec Ogo et Daba en même temps, y compris à l'argument. Donc, vous, personnellement, peut-être on ne s'est pas connu, mais bientôt, je vais rentrer en vacances. Je pense qu'on pourra se voir.
Ça sera avec plaisir.
C'est super, hein?
Ce que vous dites, c'est exactement ça. C'est déprimant hein, pour même le praticien. Alors, combien de fois pour les familles de patients ou les patients même, mais c'est une réalité. Décrit comme il faut venir sur le terrain pour voir, parce que même quand on dessine le Mali on montre le Mali sur une carte, on ne se rend pas compte forcément de sa grandeur et contrairement en Europe, les difficultés d'accès, même par les transports, quitter Tombouctou pour venir à Bamako ou même si...
Aller-retour, voilà, les transports aller-retour Tombouctou, Bamako, ça fait combien? Et quand on sait que si c'est 2 personnes qui doivent voyager, donc c'est une économie qui est ruinée, plus qu'on ne mange pas. Ça, c'est réel, hein, ce que tu as dit, effectivement, c'est la situation réelle. Maintenant, il faut qu'on pense, qu'on pousse. Nous, comme MSF, tu sais, le fait maintenant de dire, de poser la question, peut-être ça peut aussi influencer les pouvoirs de politique à prendre en compte. Vraiment, il y a une situation qui est là, il faut répondre, il faut donner des solutions. C'est une obligation pour eux aussi. C'est la même chose que les autres maladies de santé publique, quelque chose. Donc, je pense que si le débat est ouvert, un jour viendra, on espère, on pense que ça va changer.
En tout cas, au plaisir et j'espère qu'on va se voir bientôt.
Oui, du courage, hein, du courage. Hein,
merci beaucoup.
C'est pas facile. Merci.
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 Allô, bonjour. C'est Philippe Dunton. J'espère que vous me voyez maintenant. J'étais connecté, je vous voyais, mais là,
Bonjour Philippe. Oui.
Ça va bien?
Oui, ça
Content
va.
de vous voir. Tout va bien, Dakar?
Tout va bien, ouais. Et toi?
Bah écoute, ça va. Voilà,
d'accord. Donc là, on est en pause. On reprend dans 3 minutes.
Ok.
On reprend à 45, ouais.
Parfait.
On a le temps de prendre de l'eau, un peu de café. Voilà.
Ah ben alors, je vais faire ça parce que justement...
Salut Marie.
Salut Isa.
4 minutes pour le café.
Ok.
Tu vas au Niger, toi, la semaine prochaine?
Ouais, je quitte lundi, oui.
Très bien.
Et toi, pareil,
Oui, oui.
hein? Ouais,
Lundi,
c'est
lundi.
ça. Ouais, ouais.
Hello everyone.
Hi, Kevin, ça va?
Oui, ça va.
Ouais.
Bonjour Philippe.
Bonjour, j'étais parti me chercher un café.
Mais moi aussi. Tout va bien? Ça va? Merci hein, d'être là. C'est chouette.
Non, bah avec plaisir.
Salut Kevin. Coffee Poissy. Très bien. Alors, on va récupérer Marie-Hortense.
My Billy Bragg.
Salut Marie-Hortense. Et il nous manque Adeline. Bonjour.
My Billy Bragg mug.
Oh my God, of course. Who else? Kev, who else?
Je suis là.
Bonjour Adeline. Alors, bah, ouais, il est 44, on va laisser encore 2 minutes hein, et puis on va démarrer. Donc Philippe, oui, vous avez un casque hein?
Oui,
Okay.
Moi j'ai un casque.
Ok, c'est bien.
Ça me donne l'air d'un hamster, mais c'est beaucoup plus confortable et c'est beaucoup plus précis en termes
Je
de
pense
communication.
on a 2 traductrices hein, qui travaillent
Ouais, il
avec
faut que
nous,
j'essaie de parler
qui
pas
nous disent
trop.
qu'il est vraiment important de... Enfin, c'est rassurant, c'est plus simple pour elles en tout cas. Ouais, donc faites attention aussi à la vitesse avec laquelle vous parlerez. Mais je pense qu'on en a parlé ensemble déjà la dernière fois. Enfin, il n'y a pas de raison que ça ne marche pas. Ouais, je pense qu'on va démarrer. On n'a pas perdu tant de monde que ça. Donc, c'est plutôt...
We're going to start. We haven't lost that much people along the way. We've had quite interesting discussions so far. And later on, when we have the wrap-up session, we will try about future avenues. But In the meantime, we'll tackle the fourth session, which will be dealing with malaria and nutrition. And I'll try and see why we've put these two topics together, whether it is consistent to have them together in the same session. And yesterday, we thought it was also coming in a timely way to start our debate with vaccines. And we've already talked about malaria vaccines yesterday. And we'll talk about it on top of seasonal prevention of malaria. I would like to thank the speakers of this last session, and I will give the floor to Marie-Hortense Koudica. She's the head of the medical cell for MSF France in Dakar, and she's going to introduce our guests. You have the floor. The housekeeping rules do not change. So for those of you who wish to ask a question, you may raise your virtual hand, and I will be chatting with Marie-Hortense on WhatsApp to also manage all the questions that will be put in the Q&A box. Thank you, Michael, for this introduction. Dear participants, good morning, and thank you for having accepted to take part in this last session dedicated to access to health products for nutrition and malaria cases. Nutrition and malaria are indeed the topics we're going to talk about that are still a big focus for MSF, because malaria and malnutrition are problems that MSF teams have to tackle every year in the countries where MSF operates, mainly in the Sahel countries. For instance, just to give you some figures, in 2021, 32,000 children approximately were treated for severe acute malnutrition in the OCP projects in the 4 countries that are under the umbrella of the Dakar cell. Regarding malaria, it's approximately 260,000 children who were treated for malaria last year. So these figures demonstrate how important are these pathologies for our operations. There's been quite significant progress made over the last years regarding the development of diagnosis and treatment tools, as well as models of cares and strategies. For nutrition, for instance, we may talk about standardization of diagnosis tools allowing to classify malnutrition with all the weight-height ratio tables. And there was also the marketing of RUTF, ready-to-use therapeutic food, which were truly a revolution to treat malnutrition in the early 2000 years, to allow for outpatient treatment and decentralization of care down to the community levels. And regarding screening and diagnosis, it was only limited to the health structure by health care workers. Well, today we're talking about a screening by families themselves with the MUAC. And there have been some studies also about exclusion criteria, adaptation of protocols. There were also some progress in defining combined therapies with the full package for the prevention of malnutrition in infants in order to reduce morbidity and mortality. And for malaria, And we will remember that chloroquine and quinine were combined, and we have now artemisinin-derived therapies. And combined therapies, we've moved from presumptive diagnosis made by the clinician up to the confirmation with the RDTs, rapid diagnosis tests that we're using today. And regarding these RDTs, we've seen that it is possible today for a non-medical worker in the community to help and treat a child with malaria. In Sahel countries, the very high rates of malaria amongst the pediatric population seem to remain very high, and seasonal malaria chemoprophylaxis has been efficient up to 80%. And this efficacy seemed to be challenged because of the difficulties of following up the patients in the field and the lack of compliance problems that we're going to discuss in this session. And also, MSF have invested for a long time in developing these solutions, and MSF doesn't seem to be present anymore in the debates regarding the management of severe acute malnutrition, including prevention of severe acute malnutrition, or SAM. And other organizations such as ALIMA are far more present in these debates than MSF. So what are our objectives for the future today? What are the hurdles and obstacles when it comes to access to appropriate nutrition for the prevention and treatment of children with SAM? What is the strategy or the right model of prevention or early management of malaria? What are the possible solutions that we could design based on these findings? So these are the questions we're going to discuss during this session. We have a very rich panelists group with operational organization, manufacturers, and funding institutions or policymakers involved in designing solution strategy. We have Kevin with us, Kevin Fallon, who holds a master's degree in health, and he's currently the nutrition referent for ALIMA. In addition to the technical support in the field, Kevin is also providing a great help in documenting operational research and clinical research in the area of nutrition. Before joining ALIMA, Kevin did work for a long time with MSF for slightly more than 10 years. He was involved in crisis communication in the working group on nutrition. Kevin, is your camera on? Yes. The second expert is Adeline Lescan, who graduated in agronomy and development sociology. Her first experience in the field was in a health program in Malawi, and then she joined NutriSet, which was founded by her father. And she's worked a lot in the development of the international network of producer of therapeutic food with Plumpyfield. And today there is a factory in Niger working with NutriSet. And she will certainly tell us more about that later on. And she's currently the General Director of NutriSet. So welcome, Adeline. Good morning, thank you. And finally, our last speaker and expert is Philippe Duneton. Philippe is a doctor by training specialized in infectious diseases and public health. He's currently the General Director of UNITAID, which is an international organization purchasing drugs, pooling the purchase of treatment, medical treatment, in order to obtain the best prices, particularly for developing countries. So welcome, Philip. Thank you. And good morning to all the participants and panelists. I'm very pleased to have the opportunity to be part of this panel. So as a reminder, we will have a two-part in this session. The first part will be, first of all, listening to our panelists, and the second part will be a Q&A session. Participants will have the opportunity to ask questions to the speakers by raising their virtual hand or by using the chat function. I'll start by giving the floor to Kevin, who currently works with Alima. I know that over the last years, you've worked quite a lot on nutrition, and you were strongly involved in the Sahel countries. Could you please tell us more about the latest development regarding malnutrition? I'm thinking about the screening by the families of infants with the MUAC and the various protocols and the prevention with the package given for infants to cover up to 1,000 days. Could you please tell us about the current situation regarding diagnosis, treatment, and prevention? Kevin, you have the floor. I'll be speaking in English. If you use the Zoom, at the bottom you have a globe which states interpretation.
So thank you for having me. And so for the last decade, Lima and our teams, we've treated more than 100,000 children for severe acute malnutrition throughout the Sahel and Central Africa. And in this time, we've learned that the current system for addressing malnutrition has it backwards. First, diagnosis is late by relying on healthcare workers and community health workers to do the screening. Second, treatment is late, as families usually only have access to nutritional support once their child reaches the latest, most life-threatening form of malnutrition. And then third, prevention efforts do not take into account that families have a severe lack of access to the quality and quantity of diets that little kids need to grow and develop to their potential. At best, current efforts are wishful thinking. At worst, it displaces blame for malnutrition onto some of the poorest mothers on the planet. So Alima is working to address these deficiencies in multiple ways. First, as Maria Hortense said, we have pioneered teaching mothers how to use these multicolored bracelets, MUAC bracelets, to screen their own children in the home so you can have an earlier diagnosis. Second, we've been researching simplified protocols that allow for earlier initiation of treatment. And third, we've been promoting child nutrition safety nets, something that guarantees that a child receives the nutrients that he or she needs to grow. Now, these last two areas of work are reliant on access to specialized nutritional products. So ready-to-use therapeutic foods change the ball game with regards to malnutrition. In the early 2000s, basically 0 kids were being treated for malnutrition because it required a specialized milk that came in powder form, and we couldn't guarantee access to clean water. So basically, kids were hospitalized for up to 6 weeks at a time. So with RUTF, this milk-based paste that kids can open or parents can open and kids can eat, basically a massive scale-up occurred. And today, it's plateaued at about 4 million kids receiving treatment, most of those on an outpatient basis. So they can be just treated at home, visit for a consultation once or twice a month, and have nutritional rehabilitation in about 6 weeks. So unfortunately, the scale of the needs is about 20 million kids at any given moment have severe acute malnutrition. And this is like a 10-fold increase risk in mortality. So in a sense, in a real sense, we have failed, and we need to fill that gap somehow. And today, even that progress is at risk, let alone scaling up RUTF to meet the needs. And this is in part because of a lack of reliable long-term financing, especially in areas where malnutrition is a perpetual emergency and not necessarily a factor of war and displacement, where, funnily enough, the financing can be at times more reliable. Then with regards to prevention, food-based approaches are somehow frowned upon today in the nutrition community. While access to a healthy diet is not the only thing a child needs to avoid becoming malnourished, it is a prerequisite. And in the last decade, a new tool called small quantity lipid nutritional supplementation, as well as medium quantity supplementation, have been studied in high quality randomized control trials that when something like this is given daily over a period of 12 to 18 months, it can reduce acute malnutrition, it can reduce stunting, it can reduce anemia, and it can even have an impact on mortality. And it is even shown to positively impact developmental outcomes. So this spectrum of benefits has actually led the Lancet series, the recent Lancet series on maternal and child malnutrition, to endorse SQLNS as an intervention for those at-risk children. And here we're talking about many parts of the Sahel where a blanket supplementation program would be, in my opinion, required. So Alima has run programs of this nature at a very small scale in Niger, in Chad, in places where it's really needed, in Cameroon. But, and I can say this, kids like it, and mothers like SQLNS because they see with their own eyes the benefits that it confers onto their children. So we always, though, run into a problem again of financing. So it is a modest $25 US per child per year for SQLNS. But when you multiply that by hundreds of thousands of children who would require it, it becomes quite clear that it's beyond the ability of governments to finance. So an additional financing mechanism is urgently needed, whether it's the World Bank, whether it's Gavi, whether it's some global fund for specialized nutritional products. It is needed to ensure such child nutrition safety nets become a reality in the worst parts of the world where malnutrition remains an enormous burden. And it does not need to be just SQLNS. It can be whole foods, access to whole food, access to animal source protein, different, more culturally appropriate foods. But we need to ensure this child nutrition in these areas. Otherwise, we are going to condemn more and more kids to becoming malnourished to the point of death before we offer any nutritional support. Thank you.
Merci beaucoup, Kevin, pour cette intervention. Et concernant
Thank you for your statement. You've worked also on malaria and malnutrition. There is a kind of vicious circle between malaria and malnutrition. So what is your conclusion about it? And what are your observations regarding to with regard to diagnosis, management, and prevention?
With this question, as everybody does. But one thing I forgot to mention was with regards to a child nutrition safety net, it has been shown to increase and incentivize the uptake of additional healthcare services. We ran a small program in Mali associating food distribution with seasonal malaria chemoprevention. And we liked it. We felt it was beneficial, but we ran out of the ability to finance it. We have seen in our 1,000 Days program that vaccination rates go through the roof, greater than 90% vaccination rates for measles, yellow fever, etc. If we're talking about the vicious cycle between malnutrition and measles, we need to throw everything we have at it. And in the case of malnutrition and malaria, désolé, in regards to malaria, there is a new vaccine that has a relatively weak effectiveness rate, but still, it's probably going to be part of the solution. And if we incentivize the uptake of that vaccine, or even the uptake of seasonal malaria chemoprevention through a food distribution that meets the daily needs of a child with a risk of malnutrition, we should finance it.
Okay, merci.
Thank you. Thank you, Kevin. You've talked a lot about funding, financing, which seemed to be the main obstacle to the access of these quality products that have demonstrated their efficacy in the field. I'm now turning to Adeline, who is currently the General Director of NutriSet. NutriSet has become a key player for the availability of this ready-to-use therapeutic food, or RUTF. But we know that today the obstacle is the price. Adeline, before talking about these prices, maybe you can tell us more about NutriSet. And what is the basis for the development of these RUTF solutions? And beyond that, I know that you've worked on ready-to-use therapeutic food for SAM. You work a lot on supplementary nutrients. Could you please tell us more about what is happening in the field and tell us about the costs? Because I know that you are working with various factories and plants that are your partners in Western Africa. Maybe could you please tell us more about that too? Does that help, for instance, to reduce and curb the prices of these RUTF solutions? Good morning. Thank you. Thank you very much for having invited NutriSet. We're pleased to be with you. We're quite honored also, and we're hoping to contribute to this debate. When NutriSet was set up 35 years ago, the idea was to help fight malnutrition by offering nutrition, industrial nutrition-based products that did not exist before that. The idea was to put together researchers who had a clear understanding of the needs and knew what were the nutrients necessary for children, and also something that would be convenient and pleasant as a food for a child, and something that had to be tasty for the children. And we also needed to work on the whole logistic and supply chain to cover all the steps in the supply chain. So that was these were the reasons why the company was set up. This is why we started with our UTF for SAM, which was the most prevalent type of malnutrition at that time. And we started with plum peanut and we demonstrated that jointly, not only Nutriset, we could reach out many more children. And at that time, we've also demonstrated that we were able to focus much more on prevention and other types of malnutrition. When it comes to treating severe acute malnutrition, it's a failure because you're coming very late in the process of the disease. And there were two main objectives we had. Working first of all on SQLNS that Kevin has just mentioned, and also we needed to work on the business model that is beyond research. We wanted also to set up a business, a private industry that would have the capacity, which would have a positive impact. So in 2005, we set up Plumpyfield, the ambition of Plumpyfield being to provide a local industrial solution with the supply of products for the treatment of malnutrition. Today, thanks to this network, we have plants in Niger, Guinea, Haiti, Burkina Faso, Nigeria, Sudan, Ethiopia, Madagascar, and in India. We're very proud of this network. When it comes to the prices, it's another issue because it's also a commitment of the communities. Local production does not mean lower prices, but the positive impact of these plants is greater because it helps the countries to have a high quality industry, to develop laboratories, and to work with the farmers. So it's an environment that is enabling what would be the distribution, wider distribution of nutrition products, and not only last stage treatment solutions. So it's a very important step for us. That is having the tools on site, the plants to develop the new products. It means also that the local governments are more strongly involved because it's always more interesting, more attractive to them to work with local manufacturers rather than importing the products. And we also have a large sourcing area in France to export to those countries where having a factory or industry is not possible in the short or long term. We've sent more than 50% of our volumes to Yemen last year, for instance.
With regard to the products, we focused initially on the treatment of SAM and moderate malnutrition, and gradually we reached out to vulnerable populations with specific needs, such as pregnant women and breastfeeding women. Now we've decided to do more to support patients with diseases, sick patients who need to improve their nutritional status to fight off their diseases. And together with MSF, we have developed Nutrilog, which is a nutritional complete whole powder to be reconstituted with water. So we worked with MSF on this. And MSF asked us to work with them in order to improve the management of high-risk adult patients suffering of malnutrition when they enter a program for treatment. So our objective is to support the body so that the body can withstand the disease. And to come back to malaria, there are several studies that have been done, and for a long time it is wondered whether nutrition for children with malaria could be a way to attract mothers and children and then take advantage of this to provide them with treatment, because usually the seasonal malaria takes place at the same time as the shortage of food, because it's the end of the storage of what they've been able to stock up. Now, there are some preliminary results from a study which seem to me very interesting. It is conducted with the IRSS in Burkina and with Oxford University. And the study shows that if you supplement with vitamin A and plumpy dose with 50 grams, which normally helps in fighting off malnutrition. And it helped them in the study to reduce the incidence of severe malaria by 72% and moderate malaria by 50%. And you see, it shows that nutrition can be, or nutrition programs can be used not only to attract population, to give them the treatment against malaria, but it can also help to fight off malaria more efficiently. Pricing now. What we do is really focused on agri-food, and of course you mentioned drugs. Of course our remit is totally different here. We've worked with UNICEF and other bodies to reduce the cost of our UTFs, wondering whether vegetable proteins could be good enough. Dairy proteins are more expensive, obviously. So what if we were to replace them with vegetable proteins? And it's got nothing to do with our margin or as an industrialist. The cost of the product in itself is corresponds to 20 to 40% of the program cost. And you want to be very careful with the quality of products. You don't want to decrease the price too much at the expense of quality, because you see commodity prices are, well, there's not much you can do about them, but we think it's best to work on the overall cost of the program so as to get a more more impact and more quickly for the benefit of children. So obviously it's difficult to further to lower the prices any further if we want to maintain quality. Now, before we take questions from the audience, let me give the floor to Philip. Philip is going to tell us more about the funding. What about the financing schemes in the countries? Obviously, both for nutrition and malaria, countries get a lot of supports from international donors, And because UNITAID is a very large body, is a very large organizations, UNITAID has got a lot of influence. So Philippe, can you tell us how you provide financial support to the various countries? What are the criteria that are applied in order to grant these funds to the countries? Thank you very much for giving me the floor. Before answering your question, allow me to say a few words about UNITAID. All your other sessions are of a particular interest to UNITAID, like access to drugs, tests, medicines that are required, quality of products, quality of drugs, quality of supplementary food. And we do have a special focus on malaria, and obviously because we were the body that pushed for SMCs some years ago, for CPS some years ago. But of course, I want to say that it's thanks to academics and researchers in Mali and Senegal, people I was privileged to meet, and they had produced a recommendation and forwarded it to the WHO, but it had been mothballed. It had been left aside, and so we at UNITAID, we decided to put their recommendations into practice. I'm very proud about our commitment in pediatrics. UNITAID facilitated the introduction of all antiretrovirals used in Africa, more specifically. And with regard to pediatrics, we were the ones who gave the impetus to the formulation for kids, for HIV, for TB. And we think it's very important. The children are neglected patients in terms of access to care and formulations of drugs. Pediatric formulations for TB is something we really pushed very hard for. And it came 50 years after the discovery of anti-TB drugs. So we really have a very strong focus on kids and malaria in particular. So we are a donor and an influencer also. It's one of our functions, one of our, it's part of our remit. And of course, we work with people like MSF, with bodies like MSF. We think it's important to focus on these issues. It's just as important to show that it does work. I also want to say that when we started with HIV PEDS formulations, we looked into this together with Nutriset and MSF. Our approach was quite systematic, and we wanted to have a global approach to these kids that were to be treated with ARVs, and because we know the danger of ARVs for malnourished kids. So we worked very closely with MSF and Nutriset on this issue. Now, the financial support to countries, there's a lack, a critical lack of financial support for nutrition. This calls into question the role played by governments, countries themselves, and the national authorities support a lot of these nutritional programs. However, there's also need for financial support from the international community, and it is estimated at $7 billion compared with $20 billion for the World Fund. The COVID response that unfortunately does impact access to care, including care for malaria, and also impact on funds. It corresponds to $35 billion for the global south. So it gives you an order of magnitude, and some specific mechanisms that have been created, such as Unit Life for nutrition. However, the funding is not on a par to what we need. It's not up to the mark, and there are also funds that can be part of the World Fund and Gavi. However, this is not always the case. And there's also part of this which is operational research, which hopefully will help us to make this more robust. Though it may seem obvious to all of us around the table today, in terms of financial support, you need to present evidence, and because all this is evidence-based, and we need to have this evidence so that we can tie in a nutrition aspect to more general programs. And this applies to all organizations, Gavi, the World Fund, just to mention a few. Another thing with regard to funding is, unfortunately, this tendency to focus on just one issue at a time, like malaria or TB, and we lack a sort of comprehensive approach, more population-centered, more centered on people's needs. And it's important because a kid may have malaria, but there are other infectious diseases, and nutrition also plays a role. So countries and advocacy from international organizations should make an effort to be more comprehensive in their approach. And this is what we've tried to do with our colleagues at Lima. Lima and UNITAID started their work on children's fever some years ago, trying to monitor access to oxygen, but also pulse oximetry availability. This started well before COVID, the COVID pandemics, and we could see how strategic and critical oxygen access to oxygen is. But this applies not only to the COVID response. There are many other benefits to be derived from the availability of oxygen equipment. This is why it's important to have negotiations with oxygen suppliers, as we did recently, and also help the countries to equip themselves. I think it is important to prove that it's effective. Advocacy should be more integrated in its approach. Anemia is also a good indicator of the nutritional status and of the infectious disease condition, including malaria. It should apply not only to children, but to young women, more particularly pregnant women. So we need to be able to move forward and make headway. And we are exploring some avenues to try and improve our screening for anemia and the distribution of food supplements to kids and women. Of course, in this region, the Sahel, there's a seasonal impact of both malaria and malnutrition. So against this backdrop, we need to come up with programs that can both tackle this issue of malaria and malnutrition together with prevention and treatment of anemia. Some complementary approaches could be rolled out to give access to higher quality antibiotic treatments, for instance. So there are many things that must be done. You can't just hope to solve the problem with a single track approach. We need to come up with programs that are multifaceted, that meet the needs of women and children. Of course, all this comes at a cost. However, in terms of efficacy, it's absolutely crucial that we should have this sort of programs. We invested 70 million in an access project for the seasonal treatment of malaria. And now, how can we articulate CPS with access to immunization? UNITAID funded phase 4 with Gavi and the World Fund to highlight the importance of immunization. We know that immunization isn't a miracle. It's not the magic bullet. However, in coordination with CPS, it can with a seasonal treatment of malaria, it can help us to lower mortality in kids. Now, a second producer of the vaccine will be available in 5 years' time. However, it's too long, it's too far away. So with UNICEF, we've looked at the possibility to combine this tool in the area with SMC, or whether we should focus this tool on countries with a higher degree of endemic infections. We don't know yet. We haven't answered this yet. How can the countries get access to this? Well, first, rely on evidence-based approach, issue recommendations that can be serve as a guidance for programs. And we look at countries' needs, not as such, because it's not part of our objectives, but we want to design programs that can be then taken over by other donors, such as the World Bank or the World Fund or Gavi or others. I'll leave it there, and because I want us to have enough time for questions and discussions.
Puisque tu mets en avant le fait que les financements
It's very important what you just said. The financing isn't up to the mark. But I feel that the most important comment you made, and it's maybe one of the limitations, you tell us that there's also a lot of work to be done in order to have an integrated approach, a comprehensive approach. And of course, this refers us back to the patient-centric approach, because there are so many programs in the country, which means that one woman, one mother, mothers will have to visit different centers because one is for nutrition, another one is for this type of problem, and so on and so forth. So we need to rethink our practice. I think we'll come back to this point, no doubt. There are some questions now that I'd like us to take. Let me start with the question raised by Evgenia in the chat. Evgenia, I know that you're with us. Can you take the floor to ask your question directly? Hello, everyone. My question is this one. It is to Kevin. I was asking Kevin what could be the role of family support for malnourished kids and the psychosocial approach, and what can be done from this angle for malnourished kids, and the link with patient-centric approach.
Ok, merci.
Et bien sûr, merci beaucoup à tous les.
And thank you very much to all speakers. It's really very interesting.
D'organiser sa réponse.
Well, give some time to Kevin to give you an answer. I would like to give the floor to Jean Hervé.
Hello?
You'd like me to respond?
Maybe we will wait. Jean Hervé wanted, yeah, to intervene before. Yeah. Jean Hervé, est-ce que tu es en ligne?
Jean Hervé, are you with us? Yes, I'm with Elba. I don't have much to add at this stage. I think there are three issues that are intertwined, preventing SAM. All of us, we accept and can acknowledge the fact that we failed so far, as Kevin showed. Then secondly, the treatment of infectious diseases and the potential contribution and help provided by enhanced nutrition. Well, it seems that we've improved on this count. However, I think it's best for me to leave more time to my colleagues to express themselves. So Kevin, over to you for an answer to Evgenia's question.
I think that's not my area of expertise, but I think we can always do more for psychosocial support for individual families that we come in contact with, especially. But I did want to say one thing, in terms of the mental health well-being of mothers, there is plenty of research in the West and the North showing that if you relieve the stress of food security, especially food security for your infant, then you improve maternal mental health well-being. So we're testing this hypothesis in Ouagadougou at a small scale, but we hypothesize that women participating in this supplementation program where it's guaranteed that their child receives nutrition, the appropriate nutrition that they need, then we assume that their mental anxiety, mental stress is going to be reduced. So we'll see, though. That's being tested right now.
OK, merci. Je donne la parole à Thierry Alafort qui a levé la main.
Thierry Alafort wants to make a comment or ask a question.
Merci, c'est un peu une...
Thierry, on ne t'entend pas. Ah, OK. Ouais.
Vous m'entendez?
Can you hear me?
Là, ça va, ouais.
OK, go on.
Bonjour à tous.
Hello, everyone.
Cette question, bonjour Philippe, bonjour Adeline, elle s'adresse...
Hello, Philippe and Adeline. This is a question to you more specifically. However, as Kevin said, we've improved in the treatment of malnutrition. Jean-Hervé said we also combine this with the treatment of infectious diseases. We still have more of course, some area for improvement. However, either the products are very expensive and we can't lower the cost, and on the other hand, the financial support is on the downward trend, and since you see there's really a drop in funding. Some countries are responsible for that, obviously, but it's by far not good enough. Technology transfer doesn't work, as Adeline explained, and the financial support isn't available or sufficiently available. So what would be the solution according to you, if there is a solution? I want to come back to the price of products. Our UTF, for instance, costs 75 cents per day. I didn't say expensive, but I didn't say expensive that the products are expensive, but you can't lower the price any further. Now, I'm not trying to argue that the price is right. It's just that I think it's important to put that in perspective and see how it does compare to what donors can do, because you can treat a child for 75 cents per day. So considering the cost of treatment, it's, of course we can make it a bit more efficacious. We can lower the price a bit more, unless we stop paying people for what they do in research. Don't you think that our job is more to look for financial support? There's a lack of funds for nutrition. Other diseases are supported by financial subsidies, but it's not the case for nutrition. So I think we need to work all together in order to convince donors that they have to support nutritional programs. Of course, we are ready to work and try and reduce our cost a bit. However, if you reduce the cost too much, well, you're going to see that outsourcing is going to be in Pakistan or India, and quality is going to decrease, and Indian products are going to be sold in Niger, for instance. So, no, my take on this is not to say that it's too expensive. It's just that you can't lower the price any further. And if you look at Niger and you mention prevention, 300 million euros for a country. Well, we find it very difficult to convince the authorities. And obviously people turn to other products that are cheaper. So on the one hand, there is one effective product which has a given price, and we can't lower it any further. And on the other hand, a lack of funds.
Kevin wanted to respond to Thierry's questions. Kevin, you have the floor.
I think Thierry sort of touched on something that's very important, and there is no easy solution. So the price of these products, we need to find a way to reduce them, but it's not sort of your classic big pharma price gouging that's driving the price. You know, it's basically the raw materials. You know, and we want to simultaneously do several things. We want to reduce costs. We want to have increased local production, which puts pressure on increasing the cost. And we want to have more culturally appropriate foods. These are all very valid goals. And they're not difficult to, or they're not easy to put together. But I do know that if there was a source of reliable financing, Dr. Philippe mentioned the $7 billion a year, which is basically a rounding error in some international financing mechanisms, is basically what the World Bank has estimated it costs to address malnutrition at the appropriate stages. And I think a lot of that money would be going to specialized nutrition products or investing in more local factories. I think STA, the Nutricet affiliate in Niamey in Niger, they produce a very fine flour, a weaning flour, so a child weaning food that is quite appropriate. So in my opinion, it's going to require all of the above. And in fact, it requires first and foremost, though, that the financing reaches the needs. Because this dynamic where ECHO is constantly reducing the financing available, where the supply chain managed by UNICEF is constantly buckling, and there are stockouts, and there are manufacturers that don't have a clear sense of what the demand is, even though we know what the demand is, because of financing shortfalls, that dynamic we need to end. So we can start addressing some of these other questions that will contribute to a more sustainable response.
Oui, si je peux intervenir, je pense que Kevin, tu as.
I think that Kevin is. It's a spot-on comment regarding the various challenges. As UNITAID, we talk about broken markets for all the reasons that you've just explained, that is assessing what is the actual demand and what are the funding solutions. There is no silver bullet and there is no magic money, and there are constraints and even more greater constraints if you consider the needs for replenishment. And I will talk between Gavi, CEPI and PEPFAR and World Bank, because this will be discussed at the end of next year by the of this year, sorry, with the US Congress. There is this whole issue of funding. There is no miracle solution. On funding, there are budgets that are earmarked for development projects. Now, the question is, are there any other sources of funding? There are innovative projects. The tax on flight tickets has been suspended because of COVID. We have made effort in France on the tax of on financial transactions. That's 800 million euros per year that are levied in France, only in France, and it helps to give funds to Gavi, to UNITAID, to the Pact for Education, the Green Fund, etc. There were hectic debates in France. 11 countries were ready to do that, and 5 countries, and then Brexit came in the debate, because countries wanted to be present on the financial market as substitute to the UK. So they wanted to avoid a transfer of funds outside to the UK because of Brexit. A tax is never a popular solution, but taxing financial transactions which do not have any political impact and which shouldn't be a problem for the lay people is something to be discussed again, maybe, because the money that goes to development today is kind of capped and reaching its limits. And if we do not find any additional funding mechanisms, I'm afraid this debate will be repeated over and over year after year. I also wanted to underscore what Adeline said. Let's not forget that a price war may have consequences in terms of quality and markets. With TB, for instance, 20 years ago, we were faced with a situation where some products were marketed at very low cost, but their quality was just poor. So it took years to correct this and catch up with this. So let's not forget what happened. We have to pay great attention to that, and we make sure that we have met all the conditions to come up with quality products, including local production with a direct and indirect fallout. We've seen that COVID has had an impact on local security of food and handing over to producers that are far and remote will not solve the supply chain problems. So these are my thoughts regarding this particular debate. Thank you, Philippe. Adeline has raised her hand very quickly. I don't know whether it was about to respond. Very briefly, just to give you the example of SQLNS and how you can have some funds. When the paper was published in the Lancet with endorsement of Lancet, the World Bank has put in Burkina Faso and Madagascar some projects of $100 million for each country with the use of these products. So when you give a demonstration with evidence-based demonstration, the budgets can be made available. I'm not a specialist of budget and funding, but it does happen sometimes. Thank you, Adeline. William has also asked a question in the chat. William, since you're connected with us, can you ask your question? You have the floor. Thank you, Marie-Hortense. It's more a comment rather than a question. It seems that based on the direct observations we've made in the field, there is an underestimate of the actual needs. What I've put in writing is that we don't know. In Musala in Chad, there were 3 times more people than what was officially counted by the government and funders to provide supply for the fight against malaria and malnutrition, etc., that local health workers do not understand, do not know how to put an order, so they do not receive the right quantities or the order products that are not actually meeting the needs. So there's a huge teaching and education work to be done to make sure that is done properly. The partners' contribution in terms of supplies are not considered in their orders. So on top of the underestimate of needs, you have an underestimate of needs made by the field. If you don't have the proper data from the field and the state, sometimes we supply only 10% of the actual needs. I'm saying 10%, but I think we're not far from what is actually observed in the field. They're quite surprised when they hear what MSF says when we have a project where there is no partner, little staff, and few patients. In reality, the needs are underestimated because patients will not show up. And in reality, the needs are underestimated, so the budgets are underestimated, and that's a major problem. I'm setting aside all these issues about additional funding needed, etc. But what I've observed in the countries where I operate is that there is a problem of large-scale underestimate of the actual needs. Thank you, William. Indeed, this is a problem for the field. And the question, therefore, would be, what is it that MSF can do to improve this? There is a funding problem, but it might not be the only problem. There is the whole model behind all this that we should be revising, including working with the various MOH of these countries to properly plan the needs. And the data of the MSF programs are not always included in the data of the MOH. So indeed, therefore, it is difficult to actually estimate the needs for funding. Michael, you have the floor. Thank you, Marie-Hortense. You've just talked about it as well as William. I'd like to talk about the public authorities. The countries that we're talking about are countries where the situation has not been very rosy over the last week, whether we're talking about Burkina, Niger, and Mali, and Chad. Niger might be an exception, though. No, it's the one-off situation, and it does have an impact on the way we work with them when it comes to access to vaccines or nutrition products for children. So maybe Marie-Hortense and Kevin, Mary. So we were wondering how MSF can mobilize the governments to work with us on this, how we could cooperate with them at a time where there are huge tensions in these contexts and these settings. Kevin, you have the floor.
So I'm not an expert on financing mechanisms, but there has to be something. I think Elon Musk recently said, "Where's your plan?" Well, if Elon Musk created an endowment of $1 billion US dollars, this would give us $50 million a year. He can keep his principal in 10 years, but this would give us $50 million a year dedicated for specialized nutrition products. Development agencies like the World Bank, of course. So they're developing their plans now. So the Lancet series did add a degree of momentum in some instances. So for Burkina Faso, a one-year program for 100,000 kids, it's great. Madagascar as well. But it didn't add the momentum to include such an intervention in Niger, which is perhaps the hotspot of malnutrition in the world today. Even though they're investing tens of millions of dollars, $100 million a year, in which they say it's for addressing nutrition, but you look at the actual interventions, and those interventions don't have the evidence that guaranteeing a child's diet has. So I think Andrea Bussotti asked in there, like, what's needed beyond the evidence of the Lancet? And you know, these studies that the Lancet talks about are really incredible, because they basically say that if we give a kid a good diet with the nutrients that he or she needs, she does better, he does better. And it took us 10 years for that. I'm sorry, if we spend the next 10 years arguing about how do we actually intervene in such a way, it's going to be an incredible waste. And in terms of the financing mechanisms, they did it for malaria, they've done it for TB, they've done it for HIV/AIDS. We can do it for nutrition, getting the people who have the expertise on the case. And otherwise, it's going to continue to be one of the greatest moral political failures of our time, that little kids need to starve to death before we actually intervene nutritionally, and even there, only a quarter of the time.
OK. Kevin a répondu à la question de...
Kevin has answered Andrea's question. Andrea, are you happy with this answer? And after Andrea, Isabelle will have the floor. Thank you. I hope you can hear me. Yes. Yes, yes, we can hear you. Thank you, Kevin, for your reply. It's a bit provocative as well. I think that we put a lot of hope in operational research, as we've done at some point in the past, and this area, it's also a question of common sense. You know, feeding properly a child does help for the child to grow and develop. And Alima have taken over after MSF and have given a demonstration that it's not only a proof of concept, that it does have an impact in real life. But what are what is the operational research that can help change the view on that, change the scale, because we're faced with this obstacle? But is there a way to develop a different strategy?
I think for now, right now, it requires operations. I mean, you can call it operational research, but it requires operations. You know, MSF Epicentre from 2005 to 2010, we're demonstrating something similar with different kinds of foods that were good, food plus cash. You know, this was very instrumental in my own thinking. So I don't think it's anything new. So for me, I would move away from operational research. We can answer certain questions, like for me, whether or not these supplementation programs do incentivize higher vaccine uptake. You know, we've modeled it, and it does. We've modeled cost effectiveness, and in the model, the cost effectiveness is good. But let's apply that to real life, and that requires operations, not just operational research. I think we're past the time where we can just chop off the research component, and I'm at the point where it's like, how do we start to scale up to an entire district in Niger? And this is going to require financing. It's going to require answering different questions. We didn't even talk about the environmental impact of, you know, if we give this to 100,000 kids a year and one a day, what's the, you know, we need to address the environmental impact of this. But these questions should not come at the expense of starting these operations, in my opinion. We can start to answer some of these questions as we're running these operations at a scale that is more beneficial than just 500 kids in an operational research study.
OK, merci. Isabelle, à toi la parole.
Isabelle, you have the floor. Thank you.
Bon, bref. Oui, moi, je voulais répondre un peu à la question de
I wanted
Michael.
to answer Michael's question. It is true that currently the region is pretty unstable, but there are opportunities.
Le conflit au nord Nigeria, à Katsina,
In Katsina, North Nigeria, the conflict is spilling over in Niger, but it could be an opportunity because today what funders are interested in for this region is are the conflict zones. They focus on conflict zones. So maybe we could combine malnutrition and conflicts and come up with some ideas, because we see that there is an overflow of children from Nigeria reaching Niger. They are at a very late stage of malnutrition with medical complications, as opposed to Niger children. They're not hunger refugees, but insecurity refugees, I would say. So maybe we could put this question back on the agenda and try and tackle the problem from this angle. And also recently, we've heard in Niger some statements from UNICEF about the limit that we're reaching with treating 400 to 500,000 children with severe acute malnutrition. The health system is fully congested. There is a feasibility problem, and we start and hear from UNICEF that it's no longer viable, that the problem of malnutrition will have to be tackled much earlier on. Now, with these two element in the context, Alima is very present, but MSF will certainly need to be more involved on response to malnutrition. And I fully agree with Kevin when he says that it's no longer operational research. It's about starting actual operations that will improve the nutrition of children with this objective of a healthy growth for children. We still need to make some effort to convince people internally. Everybody knows that a child needs to have a different element to grow, but at MSF, we still focus on acute cases and severe acute malnutrition. So we should go beyond that. And the other point we should need to work on, I think, is scale up and have much bigger projects. And here I'm not talking about operational research. We should review how various countries have indeed reduced their malnutrition rates, because small quantities, this idea of small quantities and this wide distribution of ready-to-use therapeutic food, when we have small quantities, we reduce the quantities because there's no funding. And in my view, that will not be enough. It's a concentrate of milk, lipid, vitamin, etc., that are absolutely key for the growth of children. But I don't think it will be good enough. We should go beyond that. Thank you for these thoughts, Isabelle. We have 4 minutes left before closing this session. Adeline had raised her hand again. Evgenia has highlighted the fact that it was important to put the emphasis on prevention. And that's also what Isabelle and Kevin have said. A very quick statement from each panelist to conclude this session on malnutrition and malaria. And then Kevin will have 1 minute for the conclusion and what are the possible solutions to be considered to tackle these obstacles. And then Philippe will finally highlight what are the take-home messages from this session. Adeline, I just had a question about, because there is evidence on many things, but what is it that has helped to have funding for other diseases that we haven't achieved for malnutrition? That's maybe another thing to be worked on. How is it that there were some funds for other diseases and not malnutrition, while we have evidence that there are solutions that do work now? When it comes to optimization, there's one thing that we haven't discussed. These are the new programs for malnutrition, programs with a single protocol for moderate and severe acute malnutritions. Today, these programs are lagging behind, while we could reduce the cost and treat many more children, because the WFP and the UNICEF cannot agree on who should do what. So maybe a third party should step in and say something should be done. For the last 2 years, we have known where to go, what is the right direction, and nothing moves. Stop. I'm sorry, I have to stop you here. So that's my conclusion. And for prevention, and of course, it is paramount, be it malaria or other diseases. Okay, Kevin, you have the floor.
I think the last point I'll say is, this question of a child nutrition safety net builds on itself. The success of the first year continues on into the next year. If you start to reduce the number of kids who are getting malnourished in year 1, and then in year 2, you have a whole cohort of kids who've never experienced an episode of acute malnutrition. It's not a silver bullet. It's not the only thing that's going to do it. But like I said earlier, a good quality diet is a prerequisite to addressing malnutrition and needs to be financed now.
Ok, Philippe, pour terminer.
Oui, merci beaucoup encore de ce débat.
Thank you very much for this
que je perçois, c'est qu'il y a sans doute,
discussion.
en écoutant Kevin et d'autres, c'est peut-être moins effectivement une question de recherche opérationnelle, encore que, comme
I listened to Kevin, and he said that some things can be done for operational research, but maybe it's not just a matter of operational research, obviously, and maybe it's important to have an investment case. It would make it possible to highlight what is obvious to us, but not obvious in the eyes of the donors. I don't know why, but obviously this is the case. And UNITAID would be very much interested in having this investment case to show the donors that, be it for malaria or other infectious diseases, as Kevin says, if you can treat a child, it's not just something that you do 1 year, it's going to have an impact in the years after that, and it's going to have an impact on mortality and health in general. So we have a so many fragments that we need to put together. I'm not so sure people are keen on financing an organization that would be solely dedicated to nutrition. However, maybe we can make sure that more funds are channeled to support malnutrition programs. And we mentioned FAO and UNICEF.
De réfléchir dans cette direction.
And they could be involved. If we want to attract financing, maybe we should do more to highlight what sort of outcome can be expected from boosting malnutrition in the various programs. Thank you very much. We have come to the end of our session. Now, we've reviewed a number of issues associated with the limitations and the difficulties of the treatment and the management of malnutrition and malnourished kids. We also touched upon the issues of prevention, and we discussed at length on the limitations due to the funds that are not up to the mark, up to what is needed in the field. We also say that it's important to give some thought to the various strategies that could be implemented so as to focus our approach more on the deployment of the various programs in the field. Of course, it's a very important subject, and discussions will go on next week. MSF organizes a workshop on nutrition in Niamey, and this is to pave the way for our future programs this year in light of a situation that is a bit difficult this year. Thank you very much to all of you for your active contributions, and let me hand over to Michael for some concluding remarks and for the wrap-up session. Now, thank you for your masterful management of this session, Marie-Hortense. I think we do have now half an hour to wrap up our discussions on these two sessions. And I have a couple of points to make. Before doing so, though, I'd like to mention what Eric Gomard, and I want to, greetings, of course, to Eric. I want to come back to what he says, which opens up perspectives that are interesting in my view. He was just wondering whether our current discussions illustrate the internal contradictions within MSF, because we've almost brought to zero institutional financing since September 2000. And maybe it is time today to revisit this policy of financial independence, because maybe this sort of all-out financial independence that was adopted 20 years ago, it led to a decrease in our operational ambitions. Now, thank you very much, Eric Gomer, for your contribution and for this question.
Bon, ce qu'on vous disait au début hier matin, c'est qu'il était vraiment important.
Of course, we need all of us to identify the various things or the various avenues we must explore in the future. our agenda for these 2 days, of course, reflect our concerns and our will to do things and to take actions. And of course, this is the first step. So we need to identify what we intend to do, take stock of the situation, or get the lay of the land, as it were, and see what sort of actions MSF would like to implement and can implement. And when I say actions, this means programs, but not only programs. It means also underpinning our field actions by a review of the situation, some analysis, some research. Our discussions were very comprehensive with various points of views, and this is why it's so interesting to bring to the table people from different backgrounds to get high quality, high level discussions. All of you work in different areas. You have different personalities, and this is something, bringing you together is something which is very valuable and fruitful, I think, for our discussions. Now, of course, MSF can't hope to cover all these issues on its own, as obviously is the case for cancer management. So discussions highlighted the complexity of these issues, and also highlighted the importance of pricing. Pricing has been pretty much the talk of our recent discussions at MSF. But we also mentioned capacity, production capacity, quality of production. We also highlighted the role of the patients and how important it is for us to put the patients at the very heart of what we do. The importance for us to work with all stakeholders, health authorities, patients, the industry, NGOs, other NGOs. It seems to me that our discussions also highlighted the limitations of MSF and the difficulty of working all together. However, in this landscape, MSF is not alone, and we should be a partner, or we should partner with other organizations, and we shouldn't be too keen on hardline ideology, being careful about not being caught in this. Now, all of you produce high quality work and high quality knowledge and have high level of experience. Of course, maybe we need to do more in order to coordinate all these expertise, and in order to identify the issues we must tackle and coordinate our actions. Now, let me hand over to Isabelle for some conclusions on these 2 days, and then Natalie will moderate a short discussion with all of you. Thank you very much to all of you. It is a real pleasure to organize these sessions. Thank you. Over to you, Isabelle. Thank you, Michael. I'll try and be brief. with my summary, which I sort of attempted as I was listening to you. Thank you very much for having organized these sessions because it gave us access to a lot of internal and external experts. By way of introduction, I said that OCP is in a favorable, positive situation with new tools helping us to focus on access. Jean-Hervé highlighted the various myths of health, public health, and the need for MSF to give priority to global solution. And he also mentioned the determining factors, and it's something which seems to me quite essential. Hopefully, so that was my first point. Secondly, as I was telling you, in some of our projects, there's a real opportunity to do more and to do better. Access to TB vaccine, for instance, was mentioned. However, I would like to highlight some issues and some tools that are mature and that could be used in the very near future, but there are several prerequisites to do so. With the HPV vaccine, we can see that there's a need for organizing ourselves internally within MSF to bring together existing knowledge, more particularly people at Access Campaign have this knowledge, also coordinate this, tie this in with research on the field, in the field, and also. So I gave you the example of tools that can be rolled out in our fields. It seems to me that, and you may qualify this, but it seems to me that our approach, the way we approach things is subject to contradictions. We want to solve problems on one hand. On the other hand, there are some tools such as the malaria vaccine that have to be rolled out concretely in more limited scale projects. For instance, just to illustrate my point, and this, of course, this is not really access to the tools generally speaking, but it seems to me that in several of our projects, we must provide our patients with some tools that exist, such as the HPV vaccine, be it on a limited scale. Of course, HPV vaccine is not something we can roll out overnight everywhere in West Africa, but at least if we can offer it to daughters of our patients, this is something we can do in Mali, in Malawi, so we can start at, you know, on a limited basis, like in Chad, in N'Djamena, we have a malnutrition, a nutrition program for these for kids, and I think we could do more in order to avoid these kids from being victim of malnutrition over and over again, because we do have a responsibility vis-à-vis these patients whom we admitted to hospital with SAM. We know that once they are out of the woods, this is not the end. They can still be affected by malnutrition. So we should make supplementary foods and anti-malaria drugs available to them in the aftermath of their hospitalization for SAM. So it seemed to me that there are a number of things we can do right now. We can address right away, and there are several questions that come to mind, like a malaria vaccine. There are a limited number of doses. 15 million doses are produced, which isn't that bad. And our action today, if I understood properly, we focus on advocacy so that these doses are made available and provided to a number of countries where there are clusters of malaria and countries that do not have the means to pay for these vaccines. I think we should not be satisfied with just being involved in advocacy. We should help the governments in Niger, Mali, and elsewhere to make sure that this immunization becomes reality. So we should get involved concretely in what can be done. There's yet another point we overlooked, I think, and it concerns Ebola. We've come to a point today where we know what sort of issues we're faced with, what are the proofs of concept, and how we can use this in order to use the vaccine more widely and alongside monoclonal antibodies. It's something that we can do quite quickly just by getting organized within MSF. We just have to conduct a further study, get in touch with suppliers, review the feasibility of all this, but it's a concrete objective. Oncology raises a number of issues on access to care, but there are other issues that are easier to solve, such as the ones associated with the HPV vaccine. The Access Campaign has got pretty thorough knowledge of what goes on with the HPV vaccine, and of course, there are some of these issues that are under the responsibility of the medical and operational team. And in the countries where we work, in Mali and Malawi, we don't seem to be able to use these two countries in order to set the example and show the benefits of these vaccines. Now, all these issues are, of course, complex. However, there are things we can do right away, such as availability of chemotherapy, generic chemotherapeutic drugs that are not very expensive, but not available in the countries where we work and where we intend to offer cancer management to patients. And there is also yet another point that we didn't mention, i.e. the anti-measles vaccine. We know that the current measles vaccines are faced with limitations. And with these current vaccines, it won't be possible to prevent measles outbreaks and to control them. So what about the patch vaccines? Where do we stand on this? Is there anything we can do in order to accelerate its rolling out? Now, this is a very concrete question to which there is no answer yet. MDR-TB, has been the subject of massive investment thanks to UNITAID as far as research goes. However, what is missing from our operations and projects on MDR-TB, despite this massive investment on research, and despite the opening of 2 projects for which I hope we'll see a lot of patients to be treated for TB in the Philippines and Pakistan. However, we're still missing a real take on how to use these new molecules and how they can be used by the states, and what sort of obstacles have to be overcome to get access to these molecules, and more particularly in the Philippines and Pakistan, where we have these 2 projects. How can we use these 2 projects to demonstrate that these molecules can be used more widely? So how can we tie in research and operations, in other words? We also mentioned nutrition. I do agree with Philippe Duneton. Who wants to support an investment case? I do agree with you. This is what is needed. And finally, and sorry for these sort of bullet points I'm giving you, but the last one is very important. It's mental health, psychiatry, and psychiatric drugs. There's a project within OCP and at WACA, and probably in other sections as well, supporting mental health patients with drugs that may not be necessarily very expensive. It's another avenue we need to explore. So this is what I wanted to share with you. For the past 2 years, it may be that we've been hampered by the COVID pandemic. However, it seems to me that despite the pandemic, it's still feasible to make headway. And I think each of the bullet points I put forward would require a session and discussions between ourselves. But I think we can do so. We can also have these questions debated among ourselves and with the Access Campaign people. I'll leave it there. And over to Nathalie. Yes, let's do so.
Thanks, Isa. So I'm just going to wrap up, actually. We've only got 5 minutes left. Just as Mikhail said, what we wanted to do these last couple of days was have a couple of mornings, 2 mornings of discussions with these people who are working on these particular subjects, inside and outside MSF, working in different ways with different approaches, but working generally towards the same ambitions, and ambitions that are shared by MSF and by the operations of MSF. As we said at the beginning, we wanted this to be really the start of a conversation around a few examples that we think are important, that are important to MSF, but we know there's plenty more, and Isabel has already started mentioning some others that we've been talking about for a while, and that are definitely also equally as important. We really hope it was a useful couple of days, and what we really hope is it provokes that type of reflection, but also ideas, dreams, ambitions in the minds of our operational colleagues and practitioners in MSF today. We also hope that it gives you some idea of who else is working on these subjects, who else is interested in these subjects, and what they're actually working on in their day-to-day lives in this big machine that is MSF, MSF France, but bigger beyond that. and also beyond MSF. And we've invited some people from outside MSF who can also bring their perspectives to the table. We don't really have time. If anyone has any pressing thoughts or comments they want to make, then welcome to contribute those. But I think it's probably best maybe just to wrap up, and we can continue the conversation in the coming weeks, months to come. I'd just like to thank everyone who participated today and yesterday, for all your thoughts, for your comments, for your contributions to this collective discussion that we wanted to have together. But also, I think we all want to particularly thank Mikel and I definitely, and Jean-Hervé would want to particularly thank the people who helped us make the videos, the preparatory videos. And I do recommend that if you haven't watched them yet, do watch them, because I really think that they're very good and they really help trigger some thoughts in my brain. I learned an awful lot. And I also really want to particularly thank the people who helped us organize these days, and a special mention to Rachel, Gerta, Sabrina, who've been working very hard technically behind the scenes to put this all together. Joelle as well, who helped us with setting up the conference. Loic at production, who helped us make the videos. And a really special thanks to the translators, who do a really, really amazing job, and it's not easy, and they've really helped facilitate these couple of days. Thanks everyone for coming, and we'll keep in touch. Bye.
Thank you all.
Thank you.
Thank you.
Merci, au revoir.